Thank you.
Yeah.
Okay.
Yes. Assalamu alaikum ji. Good afternoon. Dr. Tahir here. First of all, in the announcement, my name was not correct. They mentioned Tahir Anis. I don't know. Okay. As per request, I'm just going to talk about organizing an inpatient acute pain service. So just keep in mind, I will not talk about any details about pain, acute pain, chronic pain, or these definitions, but just I will concentrate on how to establish an acute pain service, and especially do we need it. I don't know how many hospitals in Pakistan they have acute pain service, but I'm sure it is not very common. So just just a minute. Yeah. So first of all, question is, do we need ABS? A general concept, not only in Pakistan, I mean, it was everywhere before and still at many places, that we as anesthesiologists, we treat pain intraoperatively. And later on, it is the responsibility of the surgeon to take care of the patient about pain, antibiotics, and other things, whatever. But we are not concerned about post-op pain in the ward, especially after hours, after the patient is discharged from the PACU. So acute pain has two components. One is the non-surgical condition, when patient is not coming to operating room, but patient is still in acute pain. So who is responsible for that? Patient could be under surgical care, under orthopedics, under general medicine, or patient may be in ER. So, but patient is in acute pain. So who will treat? Who is responsible? We will talk about this one. And second condition is the surgical. And surgical again has three components. It is preoperative, intraoperative, and postoperative period. First, APS team was established in 1985. So you see, before 1985, it is not very far away. I mean, before that, there was no concept of acute pain service. But even at that time, regional anesthesia teams were working. And they were taking care about the limited number of patients with catheters, epidurals, nerve blocks, like that. It was started at Keele University Hospital and at US Community Hospital. And why it was started and the reasons they found for setting up such acute pain services was insufficient post-operative pain control, especially when patient is discharged from acute pain, PACU, post-anesthesia care unit. And what nurses lacked experience how to manage their pain. And very important factor which we see everywhere is time and staffing. For example, in my hospital, if you go to the ward, each nurse has about 5 to 6 patients. So she is running here and there, scheduled medication, checking vital signs, other complaints, shifting the patient to x-rays or other places. So they are very busy. So they cannot take care about the pain post-operatively when patient is in the ward. Then availability of patient control analgesia. Those duty doctors in the ward and nurses, they are not familiar with PCA, and especially who should order the medication. So these factors, they just thought about and started the acute pain service in 1985. In 1988, the same team they just published their first paper, Development of Anesthesiology-Based Post-Operative Pain Management. And what was the result of this study? They said new organizational structure rather than new analgesics or new techniques were likely to improve post-operative analgesia. So you see, you don't need new techniques, new drugs. You just need to have a dedicated team which can take care of these patients post-operatively, so it can significantly improve post-operative analgesia. Then there was a recent paper published in 2018. It was just studied by a cancer hospital who are doing high-tech surgery. So a dedicated team, was just 1 minute. Yeah. Okay. Sorry. So high-tech surgery is actually very painful surgery. It is laparotomy, very big incision from G sternum to pubis, and they are giving high temperature on oncology treatment. These patients are very difficult to treat regarding pain. Although all these patients had epidural, thoracic epidural catheters, thoracic epidural analgesia, but even then it was very difficult to treat pain in the wards. So what they did, they just established acute pain service, and at the end, what is their result? That service such as this should be seriously considered in situations performing these high-tech surgeries to help reduce opioid consumption and related side effects. Opioid consumption was less than 50% in these patients. Before this APS service, patients with thoracic epidural, still they need high-dose opioids. And with introduction of acute pain service, a dedicated team who can take care of these patients, opioid consumption was reduced more than 50%. So till now, we know that acute pain service can produce a significant difference in pain management, as compared to if you just leave on only one regional anesthesia technique, or you leave these patients onto the primary team, either physicians or surgeons in the ward. There are some new things coming up. They are fragmenting the acute pain service, the post-operative surgical home, a new role of acute pain service. I will not go to in detail of this. This is a very new introduction, but I will just talk superficially on setting up the initial, acute pain service. Because when you set up the basic acute pain service, then you can go to the further details. Yeah. So acute pain service, there are two models, established models. One is American model, which is physician-based, and the other one is the European model, which is mainly the nurse-based model. And again, this is the structure. In nurse-based model, European model, the CEO, of course, as a legal head of the hospital, is in charge of the team, all the teams, and director of nursing, then associate director of nursing, nurse manager, and APS registered nurses. So this is the totally nurse-based model. In American model, the chair of anesthesia, director of acute pain service, then physician members, and then the residents. So what we have here, I will just tell what we are doing here, and then how we can incorporate idea in Pakistan. So our APS model is the combination of both. definitely HOD is in charge of all the teams. Then we have a pain consultant who has post-graduation and experience in pain. Of course, one or two consultants, they are nominated as a lead acute pain service members. Then we have specialists and residents. Specialists, what we do, we just select, say, for example, 4, 5, 6, or anybody who shows interest that I want to work in APS. So we just nominate them, and by rotation or as per rota schedule, they are assigned the duties. And then residents. Residents, we have per year around 12 residents, so not a big number. So at a time, only one resident is coming to APS team. And at the moment, format is year 1 and then R3, year 3. So they have 2 rotations, 1 month each. After hours on-call physicians who are on-call in the afternoon and the night, they just take care of this APS. So we have 2 nurses. Before we had 3 nurses, 2 in the morning time, 1 in the afternoon time till evening 8 p.m. But due to shortage, we are left with 2 only. So they just, one comes early morning and the second one joins around 10 o'clock. So extended hours are covered with these 2 nurses. And I'll just let you know what we do with this. So physicians, what is the role of physicians? First of all, regional anesthesia. We just check the patients a day before on the list who are candidates for regional blocks. It is the duty of the resident. And next morning, early morning, all the patients who are candidates for regional anesthesia, regional blocks are done by anesthesia APS team. Then again, this is very important. I will talk about what is the significant outside and inside the OR. Of course, first patient, when they come around 7:30, 7:45, they go to inside OR straight away, and we do blocks on the table. And this block is done by the experienced person just to save the time, not to waste the operating time. Then for the teaching purpose and the residents, we do all the blocks outside. We have a block room where we have all the monitoring and resuscitation facilities, and residents can take their time. Teaching and training things can do happen. They can take half an hour, 45 minutes, or even 1 hour outside the room. So basic concept is by the time room is ready for next patient, the patient for regional anesthesia is ready as well. So we don't waste surgical time. Then PACU pain issues. If there is any pain issue in recovery room, APS team is called just to sort out that issue. Sometimes issues with PCA, sometimes issue with dosage drugs, or sometimes a rescue block is given in recovery room. Then labor epidurals, any cases of PDPH, again, it is job of APS team. Then PCAs. PCA, anybody, any anesthesia colleague can order PCA, but in the ward, when to stop the PCA, to adjust the dosage, it is the job of APS team. And sometimes PCA is needed, sometimes in ICU, sometimes in cath lab, sometimes in the ward for other pain conditions. So again, APS team is called for the PCA. Then pain consults, any acute pain consults, sometimes in ER and most of the time in the wards, we are called. And every day, we in the morning when we are free from our first session of the regional blocks, we go for the rounds. And in the rounds, we see all the patients who had interventions a day before, who are on the PCA pumps, or who need a pain consult. So on next morning, we just do the round with residents and with the nurses. And what is the job of the pain nurses? Daily pain rounds and follow-ups along with us. Equipment care and maintenance, all the PCA pumps, infusion pumps, it is under their custody, and they just take care um, about these equipments. And even they just take care about ultrasound machines. They refill our block trolley, needles, all other equipments, resuscitation material. They are refilled by these pain nurses. Assistance to pain physicians for regional anesthesia. For example, we are doing regional blocks in holding area or in block room. So we have our dedicated nurses. We don't need to look around for any assistance. We have dedicated pain nurses who assist us for the blocks. Then training the ward staff. You know, so many wards in each hospital. So usually it is very difficult to train all the nurses to take care of the catheters, especially epidural catheters, the PCA pumps, nerve block catheters. So it is job of, again, the pain nurses. They just target the wards where main bulk of the patients, especially surgical, orthopedics, pediatric oncology, and certain other wards, they just train all the nurses to take care of these catheters and pumps. And most important thing is data collection. They just collect all the data, procedures done, any complications happening. This is recorded by these pain nurses. And for example, to prepare this presentation, I asked my nurse, I need the last year's data. So just in 5 minutes, she just pulled out this 1 year data and she just sent me. So you see, it is month-wise, how many epidurals we did in each month, how many PCS we did, and how many peripheral nerve blocks were done. So again, we can fragment further, let's say how many upper limb blocks, how many lower limb blocks, any complications happened, who did how many blocks. So a lot of data we can pull out from all this collection. Okay, this was our, till now you have an idea what is the role of physician, what is the role of pain nurses, and how an APS team works. So organizing an APS service, if it is not there, so what we need? We need, first of all, staff. We need equipment. We need training. Of course, new techniques, especially in regional anesthesia, you must need to have training. Then CPGs, practice guidelines are very important. Wherever you set up a new service, you should have practice guidelines. Either these are the national guidelines, or some hospitals, they have their own guidelines. So any guideline which is approved by hospital management, it is very important. It provides a legal cover and it helps for a uniform standard practice. Uniform practice, again, the purpose of guidelines, as I mentioned, is a uniform practice. Especially at a place I'm working, multinationality people are working. They are trained at different places, who are Asians, some are coming from states, some are coming from African countries, from India, from Europe. So they have different kind of training, different background. So if they practice individually their own things, it will not be nice. So idea is, if you have to follow your practice guidelines, so there is a uniform practice. And then another important thing, if you start APS team, or if you have a regional anesthesia team, error reporting is very, very, very important. I know I had been working in Pakistan. Most of the errors, they are just not reported, or if they are reported, they are just ignored. So they are not properly documented, not properly discussed. So we have M&M meeting each month, 2 hours. We say, for example, each last Thursday of the month, today we had M&M. And we discussed all these errors, any comorbidities. So it helps to improve your practice, how to avoid further incidents. And then data collection and analysis and re-evaluation. So you can analyze your data, you can do it every 6 months or yearly, and you can modify your practice, you improve the patient care. So individually, if we talk about staff, again, physicians, teaching hospitals, we have a lot of physicians. For example, even at a district hospital, I saw there were 35 residents in anesthesia only. So we have, a lot of staff. So you need physicians, from the consultants, medical officers, residents. We have house officers, and we have nurses. So from all this staff, this is again important thing, select the interested physicians. So if you select a person who is not interested in acute pain service or who is not interested in regional anesthesia practice, he's a useless. So select people who are interested in this one and then build your team gradually. Regarding the equipment, you need PCA pumps, you need epidural and nerve infusion pumps. And for regional anesthesia, of course, you need ultrasound machine and needles. So again, many hospitals, especially teaching hospitals, they have their budget. Each year you can get 1 or 2 things from here, or again in Pakistan, we can, what we used to do, build up your own resources from donations, from collections like that, or just keep focusing on your annual budget from the management. Don't force them to get all the things at one time. You can get, say, for example, you can get 10 pumps a year, 10 pumps next year. You can get 1 ultrasound machine, add up 1 more next year. So like that, make a target that in 4 or 5 years, you have to build up your team and you have to complete your equipment. Like, for example, from the equipment, we have color-coded pumps. These yellow-colored pumps are for epidurals and nerve blocks. They are programmed differently, and this blue color, they are for PCA. So here again, patient safety issues. Our drugs are prepared in the pharmacy, and different program, you cannot put PCA in this program is different. This PCA program is different, and this is a jacket which is locked. 100 ml infusion is locked in this one, so no other person can modify. Drug errors are minimal with this locked pumps, and these are the coded. There is a code. If you enter the code, only then you can pre-program it or modify the program. So select the equipment which is safe, which cannot be manipulated easily by other people. Like, for example, if you use open syringe pump, anybody can manipulate that pump. For example, we had few incidents. Patients with sickle cell, of course, they come in pain crisis, and with passage of time, they develop some sort of drug-seeking behavior, and they used to modify the infusion by themselves. So if you have a locked pump, then they cannot manipulate that one. So from the drugs for PCA, we need morphine, hydromorphone, fentanyl, and now oxycodone as well, which have. And for the regional anesthesia, you need bupivacaine, levobupivacaine, ropivacaine, and questionable liposomal bupivacaine, because it is very expensive, and till now there are conflicting reports about its efficacy, what it was projected for. So, but even then, I think try to get this levobupivacaine and ropivacaine, because they are less cardiotoxic as compared to bupivacaine. And yes, this is a chronic problem in back home. Very few hospitals, they have morphine. fentanyl as well at very few hospitals. So these all three drugs are, important component for patient-controlled IV analgesia. Then I explained earlier, clinical practice guidelines are very important. International guidelines are available. There are European, there are American, there are British guidelines. You can take help of these guidelines. Even Aga Khan Hospital, Shaukat Khanam, they might have their own guidelines. You can take help from their call associate also. Again, you are very old established department. You might have your own. So, but if we have a national practice guidelines in Pakistan, it will be very good. So each hospital can get that and follow those guidelines. Again, it helps for a standard and uniform practice and legal aspect as well. For example, any complication happens, there is a medico-legal case. So what they do, they just look at that one. Did you follow the guidelines? So if they followed the guidelines, then physician is not at fault. So if you did not follow the guidelines, then fault lies on you. This standard and uniform practice, for example, you are doing a block, so you can just establish that this kind of surgery will have this kind of nerve block. So juniors or people who are not very well aware, they should not do their own experiments. And for example, I saw here a few residents, they were having their own habit of doing the test dose for epidurals. So again, this is unsafe practice. So if you have a standard practice and practice guideline that for epidural, this is a single test dose, so everyone should follow that. Then again, error reporting. A culture of confidence in improvement should be there. Not the blame game and punishment. You know why it is not reported? The physicians think it is shame for them. Second thing, they will be blamed. Third thing, they think they will be punished. Yes, at certain places, there is a problem, but not, I don't think so it is in Pakistan. But here, for example, people are afraid they may lose their job. They may need to leave the country as well. So fear is there always. But if you have a culture of confidence and no blame game is there, so idea is to improve the practice, then error reporting must be there. It must be documented. For example, you are doing an epidural, you got an dural puncture. Please document it. Tell the follow-up team. So you just follow the patient. For example, patient after normal delivery may go home second day or third day, but she may develop PDPH on fourth or fifth day. So what we do, for example, dural puncture happens for a normal delivery. So we take the details of the patient, we explain to the patient and family. We ask our pain nurses to remain with contact. They call them daily. They keep an update about development of PDPH, its progression. If it is mild, we advise them the routine management for PDPH, which they can do at home. And if it is worsening, we ask them to report to ER, and then further treatment or blood patch is done at the hospital. Then again, data collection and analysis. So analyze your data quarterly, 6 months or yearly, and it will help you to improve or modify your practice. So at the end, take home messages on the patients, pre-op, intra-op, and post-op. Like for example, we were in a phase to create a template for the post-op pain management. Still here as well. Here also, it is the job of the surgeon for post-op pain care for routine patients. Sometimes even we do, for example, a single shot block. Single shot nerve block works for say 10 to 15 hours. And then next morning, we go for evaluation and pain round, and patient complains that by middle of the night or early morning, 3 or 4 o'clock, they started having severe pain. And when we look at the medication, patient had not received the pain medication because all the medications were PRN. Medications were not regular. So this is again a gap which should be filled up. So what we do then we modify those pain medication by ourselves. High risk patients, we modify during intraoperatively, that patient should not have problem in the night or next morning. But still, I mean, this agreement is not there between surgeons and physicians. We have not taken up as a whole the post-op pain medication, but yes, PCAs, catheters, epidurals, all these are being followed up by us, or we try to modify all the medications next morning. Then paperwork, guidelines, and structure, just work on that. Select interested physicians, then and train nurses. Use available resources. This is again important component in Pakistan. Whatever you have, use that one and try to build up your resources and try to get new resources and new equipment by your own circumstances. Then efforts to create resources, again, as I said, by donations or collecting money from your known people, you can do that. And update your APS team, upgrade your APS team gradually. Don't rush that you have to do it within 6 months, 2 years, 3 years. You make a structure, and then gradually you can build up a good acute pain service at your hospital. So thank you very much. This was my presentation. And if you have any questions, please let me know.
Thank you, Dr. Tahir. Yes, do we have any more questions regarding the presentation? We have an audience. Anyone?
Thank you, Dr. Tahir. I am Dr. Khalid Bashir. Very useful tip for organized acute pain service. It needs dedication on the part of our doctors and awareness among the administration. And a very useful presentation. Thank you very much.
Thank you, sir. Thank you. Nice to see you. Nice to hear your voice and your comments. Yes, I'm always here. Anybody who needs any tips, any guidelines, anytime, I'm just available, sir.
Thank you very much.
Welcome, sir. So I think today is a holiday in Pakistan and not many participants. People are enjoying a off day.
There's no off day. Why?
I heard there is a holiday by, for example, Yom Shohada or whatever. I didn't know that.
No.
Okay. I thought that is the reason we had only very few participants. Okay, sir.
How is your routine life working? You are in
Sharjah
or in Sharjah?
No, sir, I'm in Al-Ain.
Okay.
Yeah. Al-Ain is part of Abu Dhabi.
Abu Dhabi. Okay.
Yeah.
And you do routinely acute pain service?
Yes, sir. We have one of the best team in this Abu Dhabi region. So acute pain service is very important, sir. Otherwise, and with this acute pain service, again, you are doing APS, doing regional anesthesia, and teaching and learning of your residents is again through the APS, because they cannot learn this regional anesthesia inside the room.
When did you start?
This we started in APS in 2008. 7 and 8, 2008.
Great. Good.
So, and another important component, sir, I just want to share, because, for example, there is a resistance from the surgeons, especially orthopedic surgeons, about the regional anesthesia. And the reason for that resistance is because when our people start taking time doing regional blocks on the operating table, they get annoyed because they have a long list. And they think that this is something extra, regional anesthesia, and they are wasting my time, about half an hour per patient. So then they become resistant, they refuse regional blocks. So if you do outside, you teach your residents, you teach your colleagues, then they have no concern. Rather, they are happy that we are not wasting their time. By the time the room is ready, the patient is ready. So that is the idea of acute pain service.
Absolutely true. I agree with you. When I was in government sector hospital, I used to say, give GA to first patient and then
Yes.
start local, because the surgeon, of course, feels a lot about the waste time utilized by our team. Then they also used to say, if you want to learn, apply block at the end of surgery.
Yes.
If you can learn the technique at the end of surgery, because then the usually juniors are closing the wound, applying bandage, and during that period, one can administer local and regional anesthesia and learn. Anyway, it needs extra time, extra effort of the anesthetists.
Yeah, everyone has a learning curve. It takes time to start learning and use that outside operating room, either in recovery room or your block room before the anesthesia, before surgery. So if you do the blocks before surgery, you are, no need to go high dose of opioids during surgery. So analgesia during surgery, and it is continued analgesia post-operative.
Yes.
Dr. Tahir, Dr. Ateek here from Lahore. It's just a question for you in the comment section from one of the audience.
Yes, please.
So if you can read it, if you see like in the comment section chat box. So can we incorporate acute pain service in chronic pain team by just increasing the manpower? From one of the audience asking you.
Can be, but I think if you keep it separate, it will be better. For example, yes, there are, acute pain services mainly outpatient based. You are seeing most of your chronic pain. Chronic pain you are seeing mainly in the clinics. But there are many chronic pain patients who are admitted in the hospital, and we get calls, we see the patients, we report to the chronic pain team, and then they plan what procedures they want to do or not, or they just adjust the medication. But I think if you incorporate acute pain in chronic pain, it may not be suitable, because one chronic pain consult takes around 1 hour. So, or more time. There are cancer pain, there are other chronic pain conditions. So, but acute pain has other so many things to do. They have labor epidurals. If you have incorporated some hospitals have a separate labor anesthesia team. But if APS is doing, you have labor epidurals, you have regional blocks, you have PCAs, you have pain rounds. Then to do the chronic pain at the same time, I think it will be difficult. This is just my understanding. I mean, it depends on each hospital's policy. If they think, I mean,
it all depends upon the available resources and available HR. And how much manpower do you have with you?
Yes, yes, sir. Yes, sir.
Anybody wants to ask question?
Sir, I just
And-
have a point on the talk of Dr. Tahir here. The last slide was very, very useful. Overall, the talk was very comprehensive, thorough, and covering all the aspect of the service. But I think the last slide was very, very important. Like the first point, own the patient. So if
Yeah.
we kind of take care comprehensively of our patient, then the issues that's involving the other personnel like the surgeons, that's go down the list. Because once they see you like you're really caring and you're involving, it may take 1 year, 2 years to make them realize like these guys are putting an effort and they're really are very kind of concerned about the patient's pain. So then you really come into the action there and take care of the painful aspects of the perioperative care.
Yes, very true. Very true. Pratik bhai. So any other questions or comment?
None so far. Let's see. I have no messages anymore in the chat.
Okay.
So I guess
So-
that's it.
Okay, with your permission, can I leave?
Thank
Yes,
you,
Dr.
Dr.
Thank you, Dr. Tahir.
Thank
Thank
you,
you for your
sir.
Thank you,
time.
Dr.
No
Thank you
problem.
so much.
Thank you, Sir Khalid. Thank you, Atik bhai. Thank you, everyone.
Allah
Okay,
Hafiz.
Thank you, Dr. Tahir.
Sir, thank you.